Okay, well, good morning. As it's been noted, I'm Jerry McKee, and I'm the psych pharmacist on the crew. I have known Dr. Reinstein for well over a decade. We work closely together on projects in mental health and mental health managed care, and more recently, come to know Dr. McCormick. Could not have better colleagues on the project that we're going to be sharing with you today, and perhaps an opportunity to extend access to care to persons who need medications for opioid use disorder. So as far as disclosures, when none of us have anything to disclose, as a career government employee, I'm always open to suggestions and entertaining ideas. See me after. So today we're going to talk about changes, actually in the last decade, but more recently in the last 5 years, or germane to what we're talking about today, changes in the pharmacist scope of practice in North Carolina that allow some opportunities that we're going to describe. Talk a little bit about the training that's required for pharmacists to do this value-added service in terms of administering long-acting injections. We're going to show you how you can find these pharmacists in your community, and then talk about how this model that we're going to, this collaborative model that we're going to describe can give you, it's not a grand slam, but it's another opportunity in the menu of options to improve access to care, to buprenorphine for your patients. But we would be remiss if we didn't begin by talking about, okay, how are you going to support the LAI bupe with all that we know about problems with access to transmucosal buprenorphine and other dosage forms of buprenorphine. So we're going to talk about what has led us to the path that we're at today in terms of how can your patients access bupe at their local pharmacy. There's been a number of publications about this. This particular one is from JAMA Health Forum. It's talking about just quantifying the number of pharmacies in a 3-year period that we're actively dispensing bupe to their patients. And the good news is 80% were dispensing bupe, and these are 80% of any pharmacy that dispensed at least one opioid. So 80%, the good news is 80% were dispensing bupe. The bad news is 20% were not. So this is kind of level setting, so 20%, you want 1 in 5, that can be a significant problem, obviously. In North Carolina, and this research here was done by a UNC researcher, we found that actually some good numbers. There's some kernels of positivity here. 96% of pharmacies kept buprenorphine in stock, but 62% of the pharmacists surveyed had at least once refused to fill a bupe prescription, and 55% had refused at least 3 times. And 31% have kind of mixed feelings, and there's misperceptions about ordering limits on buprenorphine. We're going to talk much more about that today. There are a lot of things that fall under the rubric of red flags, and pharmacists are taught from birth to look for red flags and follow up on red flags. These red flags could be like a telehealth script, a patient that's out of state, a provider that's out of state, paying cash. All of those red flags don't necessarily mean it's a no. It should mean, and we'll get to that in a minute, it should mean that, well, I need a little bit more information. So we'll talk about how we're trying to re-educate pharmacists and why even this became an issue. In a number of different policy settings, there have been some ideas tossed around about what can we do policy-wise at the federal level in particular to make some inroads into this. And I just get absolutely bizarre with rage when when this comes up, because this is something we can fix, and we're working on it. We're not there yet, but we're working on it. Many of you know, like in 2019, the DEA came down with the SOARS report requirement. This SOARS is an acronym for Suspicious Order Reporting System. It's a centralized national database, and all suspicious orders of controlled substances, of which bupe is a C3 controlled substance, are required to be sent into this central database. Now, what constitutes a suspicious order? Almost anything. Excess quantities outside of the norm, increased frequency of ordering outside of their norm, or other, whatever other means. And further, the DEA did not give, and continues to not provide, specific guidance to wholesalers and manufacturers who are doing this reporting about, okay, what are we reporting? You know, what are we really concerned about? So it left it up to the individual wholesalers to decide what they're going to report. So with the overarching issue of, you know, the opioid overdose epidemic crisis, COVID, increased scrutiny on the whole use of opioids for chronic pain and other conditions, pharmacists are just, you know, confused about what it is they're supposed to be doing. So here are just, and the DEA says, well, we didn't single out buprenorphine to be singled out on the suspicious orders reporting, but they also didn't say we shouldn't worry about that for the suspicious orders reporting. This is apples and oranges. So I think in terms of the policy things that can be done to improve bupe access at the community level, the best thing that could be done is for some congressional action or DEA action. If you're going to do the reporting, fine, but give some specific guidance and perhaps eliminate bupe for opioid use disorder from this suspicious order reporting. The couple of bullets here about ensuring the availability of bupe, basically requiring pharmacies to stock bupe and pharmacies to dispense bupe. In conversation with the executive director of the North Carolina Board of Pharmacy, who's both a pharmacist and an attorney, he said, don't hang your hat on those. That's probably not going to happen. But I think if we can remove the fear, and I've worked in this space a lot, and yeah, there's some stigma out there, but I think most of this, the hang up with the bupe access is out of concern for, you know, having your license pulled, having your store shut down, because we don't know what we're being held accountable for. So hopefully that is actually clearing up in the form of a set of guidelines that came out in 2024 from this is the acronym SOUP, the National Community Pharmacists Association, the American Pharmacists Association came together with the National Association of Boards of Pharmacy to put together some guidelines, some commonsensical guidelines, like until something happens at the federal level, this is what pharmacists need to do. And this soup here on the graphic shows you all the moving parts, and one of them, of course, is the red flags that I talked about. But these guidelines, who have been endorsed by the ASAM, the American Society of Addiction Medicine, the American Association of Psych Pharmacists, I mean, basically every pharmacy and appropriate medical organization that is a stakeholder has endorsed these guidelines. So now, like the State Pharmacy Association here in North Carolina is working to educate pharmacists to say, look, if you do these things and document, it's going to be okay until common sense prevails. But you know, when all this was set up, I mean, it was with the DEA and the SOARS report, without guidance, it was like, what could possibly go wrong? You know, it's just crazy. So here's what we're doing in our present work. So that's, and I would encourage you to look at those guidelines. They're always try to cheat the thing. I mean, in totality, it's maybe 70 pages long, but there's an executive summary that tells you everything you need to know, about 2 pages long. In North Carolina, how do you find a pharmacy that has trained personnel to administer long-acting injections? We have through the State Pharmacy Association, there's a pharmacy finder basically, and you can search on if you're looking for those who administer buprenorphine, those who administer antipsychotics, those who do tobacco cessation counseling. It's all oral contraceptive counseling and dispensing. It's all in there. Of course, immunizations. And currently, we're building capacity. Currently, there are 42, and I think these numbers actually are underrepresented because not all of North Carolina's 2,000 plus community pharmacies have registered yet with this pharmacy finder. 42 pharmacies are administering the LAI antipsychotics, 6 are doing the bup. And did we have a number for the naltrexone?
We didn't have it broken out.
Okay, but anyway, we did another piece of work with it. That's the naltrexone long-acting is fairly commonplace. The issue with the LAI bup was a lot of pharmacists, when the scope of practice changed, weren't clear that the scope of practice actually included buprenorphine because there's a REMS, but we have an interpretation from the Board of Pharmacy Executive Director that this is in fact okay. And so we're educating to that. So now to talk about the scope of practice updates and what the launch of the tailored plans really mean for this collaboration. For those of you who've been around as long as I have, you remember the area programs of the 1970s were really, and this is when I was a trainee in the late 70s, not early 70s, the late 70s. The area programs were really kind of a model of one-stop shopping for the patients could go and be seen by the psychiatric provider. They could be seen by mid-level for their medical staff. There was even a dispensary in most of those area programs, or there was a local pharmacy that worked with the area program. So it was all taken care of. It was fantastic. I see the tailored plans as an opportunity to go back to the future and provide whole person care, and with appropriate reimbursement and further scope of practice changes, get the community pharmacists involved. People see their community pharmacists much more frequently than their providers, so that these community pharmacists can provide support services on adherence, et cetera, immunizations, you know, kind of public health kinds of things. And they can be the canary in the coal mine and report back to the provider for perhaps an earlier intervention if they see signs of a medical need or a psychiatric decompensation, et cetera, those kinds of things. But the big part that I'm calling here the crack in the iron curtain is finally we're starting to see some payment for services. Nobody does anything for free. You do what you get paid for. So that we'll talk a bit about that. And this is just a rubric. I don't want to take up too much of the time. This is just a rubric showing over the last decade, the scope of practice has actually expanded significantly, starting in 2015 with dispensing the capacity to dispense naloxone under the standing order. And then in 2021, at the tail end of COVID, we had after, I don't know, 6 or 8 years of protracted work to get it done, we had the expanded scope of practice to administer the LAIs. We were one of the last, North Carolina was one of the last states to extend this authority to pharmacists, but we finally got there. And then more recently, in January 2024, in this past August, Medicaid began to pay pharmacists for doing things like oral contraceptive counseling and dispensing and nicotine replacement therapy counseling and dispensing for people who were interested in tobacco cessation. Now with the LAIs, currently North Carolina will pay $17.36 per injection. And part of the work that we're doing with Alliance and an association with the North Carolina Association of Pharmacists is trying to work on improving the reimbursement rate for long-acting injections and a variety of other services that are targeted toward the tailored plan kind of population. Okay, so what does it require, just quickly, for a pharmacist or pharmacy student to be able to administer long-acting injections? And pharmacy students now are getting this training in their pharmacy school training, but the currently practicing pharmacists are going back and playing catch up. And I'm sorry for the scratchy voice. It's allergy season in North Carolina. So in order to qualify as an immunizing pharmacist, you have to have a 20-hour training that includes hands-on injection training. It's pretty standard stuff to administer things like the influenza vaccine, COVID vaccine, et cetera. Then there's an additional 5-hour training that's required to administer the long-acting psychoactive and non-psychoactive injections. And the North Carolina Association of Pharmacists put together this training. Vera and I worked with some other colleagues and put it together. And so it's a really solid training. So after 25 hours of training, these guys are ready to go and work with you all to administer the long-acting injections. In terms of a patient, now I think this is very important because sometimes I get pushback when we talk about these LAIs. The provider is in the driver's seat. If you want your patient to have the pharmacy administer these meds, they can do it, but the provider has to say pharmacy to administer. If you don't want that to happen, it doesn't have to happen. It's your option, and if you change your mind later, you can always go back. But the patient has to be at least 18 years old. And then when the scope of practice was changed, the legislative language included very, very specific information about what had to be documented in the pharmacist's record. And this is basic stuff. I won't waste your time with that. But it also required specific follow-up with the provider at 48 hours for psychotropic meds and at 72 hours for non-psychotropic meds. Things like Depo-Provera, vitamin B12 would be like a non-psych med. Very, very specific. And basically it's the same information that the pharmacist is going to document in their own pharmacy information system. You know, patient name, date of birth, the med, where it was administered, when it was administered, the dose, and lot number and expiration date. And then they ship that information over to the provider, even for no-shows. And that way it gives the provider an opportunity to track down the person if they need to set a new appointment. And of course, pharmacies are also tracking down the person. I mean, that's one of the things that they do is finding the patient, letting them know, their meds are ready, they missed their appointment, you want to reschedule, or you want to just drop in. So I think that two-pronged approach can help patients stay in treatment. Okay. Yeah. So now we're switching gears. A couple of slides to show what you already know about medications for opioid use disorder and alcohol use disorder. This first study shows And this was in, I believe, 2016 to 2017. And it, of course, it predated Sublocade or Brixadi. So this is all sublingual bupe, and it shows that after 6 months, only about 34% of the people remain in treatment. And obviously, you know the ramifications of falling out of treatment. So, and we all know that MOUD is effective, but the patient has to be able to access it, number one, and then they have to be able, take the med consistently, and the penalty for abrupt withdrawal is pretty severe. In addition to acute withdrawal symptoms, you can relapse, go to street drugs or what have you, and there's the overdose potential increases considerably. But if you contrast, if you go back to that slide, again, it's about 34 to 36% remain in treatment after 6 months on the sublingual bupe. And this one is just a contrast. And both of these were naturalistic studies, not randomized, double-blind, placebo-controlled, the quote-unquote real-world studies. But this was the LAI bupe. The 6 months retention was almost double, like 70%. So it's certainly an improvement over the sublingual bupe. And then with this top bullet should be alcohol use disorder. Naltrexone is moderately effective, but then, there's still a clear correlation between adherence and outcomes. But for a brief relapse or somebody, stepping off treatment for a short period with alcohol use disorder, typically the implications aren't quite as severe as with stopping therapy for opioid use disorder. So kind of to summarize, we know these things work. Buprenorphine works, naltrexone works, more particularly for alcohol use disorder. LAIs, and so the oral versions of those are great. LAIs work even better in terms of managing adherence. And so what we're going to talk about in the next phase is, well, so what? How is this team going to share information with you that can help your patients access long-acting buprenorphine and naloxone?
Thanks, Jerry. As Jerry lined up, we've learned the benefits, the uses of long-acting injectables, both antipsychotics in the mental health space, medications in the substance use space as well. The point that we hope to make today is that our alliance's collaboration with North Carolina Association of Pharmacists, and what we're trying to show is to demonstrate the feasibility, the benefits to everybody, and some of the advantages of a collaborative model between prescribers in this space and community pharmacists. Again, we have all been taught, what the benefits are, what the right patient population is, and all that. But the whole point is to expand the utilization of long-acting injectables for the right patient population. I think back to, I love this study from 2014. It looked at psychiatrists who had the capability to administer LAI antipsychotics. Those who could do it were 10 times more likely to use them compared to those who couldn't administer LAI antipsychotics. Now, that's not going to be surprising to providers in this room, right? Like, if you could do it, you would. If it were easy, you would do it. And so the problem here is always, it's a series of yes, if only statements, right? Yes, if only I knew the medication were covered. Medicaid, guess what it is? The answer is yes, it's going to be covered. If it's Medicaid, you're good. But, is it? Yes, if only it were covered. Yes, if only I had the staff. Yes, if only I had the record-keeping ability, the time, the space, the people. Yes, if only I had the space in my office. Yes, if only I had people to track down appointments and make appointments for things like that. So the reasons that people gave that back then are just as true in 2014 as they are now about the reasons why LAI medicines are not used more. So the whole point here is that we're trying to find ways to knock down these barriers to expand the utilization of LAI medications, bupe, naltrexone, others in this case specifically. The way this works, the reason it works, is that our collaboration with community pharmacists takes advantage of the inherent strengths and the capabilities that pharmacies already have in their core line of work. The pharmacy can meet with the patient for the administration, discuss the treatment plan, begin the injection series, share clinical documentation information back with the psychiatric practice or substance use practice. The pharmacy tracks the patient, plans the timing of injections, makes the appointments, makes follow-up calls for people who don't present, can't present, informs the provider within 2 days, as Jerry outlined as required, within 2 days of a missed injection for any follow-up actions or next steps. And as Jerry mentioned, canary in the coal mine, they're not taking the place of a provider, but to say, something's not right. This person didn't look quite the same as they did before. You really should check up on them. It's one more touch with the healthcare system to help be an early warning system detection. The benefits here, all parties operating at the top of their license, and the pharmacy assumes the administrative burden, and this is the point at which they already excel. These are things they're already doing, functions they already perform, so that a provider in an office doesn't have to relearn the system, reinvent the wheel. They will manage procurement of the medication, again, which is going to be foreign to a lot of people seeing patients in an office, and the injection administration process. Thinking about the benefits to providers. So again, the whole point is to improve access. For smaller providers, often it's the smaller practices, it's the administrative burden that precludes long-acting injectable use. Either they don't prescribe LAIs or they have to send their patients to something like a primary care office to get the injection. The patient has to go to a pharmacy, pick up the med, schedule an appointment, bring it to the PCP to get it. So the point is the model removes one huge barrier to increasing the use of LAIs in clinical practice. And it will help from a telehealth perspective too. The reach that you can have with LAI availability to people is tremendously improved with if you're trying to operate a telehealth practice as well. For even larger practices, again, by reducing administrative burden, the benefit here is that they can order the medicine from the pharmacy instead of doing buy and bill themselves. And think about staffing. The pharmacy is going to have the staff to take care of this for you. You don't have to worry as much about staffing due to staff being out. Also for providers too, if your patient population is being tracked from a quality perspective, quality metrics, we know that LAIs improve treatment adherence and outcomes. Thinking about it from the patient perspective, a lot of this is obvious, but just to say it out loud, pharmacies, because they dispense drugs and manage medications, they remain fixed brick and mortar locations, and they have extended service hours, weekends, walk-in appointments. It makes it more convenient for patients to access. Think about patients who have transportation difficulties, have trouble getting out of work to make it to an appointment for administration during a standard substance use clinic or mental health clinic hours. Again, think about extended hours, weekends, compared to a provider who may only be available in a particular office a particular number of days a week, and maybe not even for the whole day. The patient is already visiting the pharmacy for other prescriptions. It's a place they're already going, a place they probably already know and trust, and a place with a lot less stigma, perhaps, for some people attached to it, which can make a big difference. Think about convenience for the patient, too, in terms of, again, availability and scheduling and wait times and things like that. From the payer perspective, so speaking, for example, from the perspective of Alliance, which is going to be covering the cost of these medications for our Medicaid beneficiaries, community pharmacies, what we think about, we want to make sure that the patient actually gets the medication, right? That it gets into their bloodstream. Community pharmacies are already steeped in the idea of adherence and what they can do, what they can offer to help improve adherence. Again, from a payer's perspective, there's telehealth benefits from being able to expand the injection sites, the administration sites that are available to patients. And a big part of this, too, is waste reduction. So a significant amount, unfortunately, of all the LAIs in a current clinical delivery model are wasted. Maybe the pharmacy delivers or ships the injection to the clinic, but the patient doesn't actually receive the injection. No-show, dose change, side effect, lack of efficacy, something like that. But by that point, the medication has already been billed to insurance, and usually the claim cannot be reversed at that point. The money is out the door. In the pharmacy collaboration model, the LAI is not billed until the administration actually occurs. So the potential for waste and waste in the system goes down tremendously. I mentioned quality, and I'll just touch on this very briefly. Again, from a population health perspective, we're always trying to keep an eye on the quality of the services that are provided. In Alliance's case, we're looking at, within our network, how are patients doing, how are providers doing, are we meeting quality metrics? There are a few that apply here, and I'll just briefly mention that they exist. There's the OUD, the OUD-USC, and the POD measures. You can read this at your leisure. If you have interest in knowing more about the quality metrics that are tracked as part of the HEDIS data set in the OUD space, you can reach out to us. We have a whole HEDIS clinical team at Alliance, and Vera and I, we're happy to put you in touch with them. They will talk about HEDIS all day long if that's your game. So if you are a prescriber and this collaborative model makes sense to you, it sounds right to you, this is how you get started. I'm going to start this off. Vera's going to take it from here. First, you need a pharmacy partner. North Carolina Association of Pharmacies has a pharmacy locator app. Vera's going to go into it, where you can find pharmacies that currently have already told the North Carolina Association of Pharmacies that they offer these services. That doesn't mean that's all of them. There's some that probably haven't signed up, and that's not mean that's all that could do it. Part of our goal here is to coax and cultivate and cajole folks into expanding this capability and also make sure on the back end that they're reimbursed properly. So part of this whole effort is to give data to NC Medicaid to make sure that pharmacists are being actually appropriately reimbursed for their time taking on this really important service. But first, find a pharmacy partner. You can start with the NCAP Pharmacy Locator app, and then you can call your local tailored plan. Alliance for the 7 counties that we serve, and VIA and Partners in Trillium. If you're not sure which plan your Medicaid members belong to, call me, write me. Contact information at the end. I got a stack of business cards here. We'll help you figure it out. We'll help you track down where your members belong. We will help make sure on the back end, if you need help with this, with a pharmacy that's not already familiar with doing this stuff, we'll help make sure that we can help get it set up. Next up, community psychiatrist or community substance use provider evaluates the patient, writes the order for the medication, indicating pharmacy to administer. As Jerry said, the provider is always in the driver's seat. A pharmacist won't administer anything unless you write it on the prescription for them to do so. And they send it to the community pharmacy, and they will take it from there for further management. The pharmacy sets up the appointment for the injection. They report the information back to the provider. They set the next appointment for the following injection. So there's an NCAP toolkit to help expand these resources. And like I said, we all know the benefits of it, and we look forward to seeing this model grow in the future. So, Vera, I'm going to have you take it from here.
Great. Thank you. So I think you've heard about this app a little bit maybe now, but this app was developed by the North Carolina Association of Pharmacists basically to allow users, it could be patients or providers, to find pharmacies in their geographic location that provide specific enhanced services. We're obviously talking about long-acting injectable medication administration and management, but there are a whole host of other services, I think, that are very important for our population that you might want to look at. So don't go to ncpharmacyfinder.com yet, because I have a QR code that can get you there right now. So I can wait, don't have that much time, but maybe I'll wait a minute. So if a few folks want to sort of go there and open it up, and I'll look for some eyeballs looking back at me with a phone in their hand. All right, I think I see a few. So if you open that up on the top, you can see there's a home, and then there's a patient and a provider. So if you can click on the provider, and then scroll down to the bottom, and you can see the service catalog or browse pharmacies. Don't browse pharmacies yet. Look at the service catalog, and if you do 12 clicks, it will actually take you to a place on that PDF where it actually explains what the service set of administering long-acting injectable buprenorphine is. With previous locator apps, of which I used to promote, I would have to tell providers, yeah, but you want to call the pharmacy first, because a pharmacy may think that they are doing LAI administration, and when you call them, they're like, oh yeah, we'll send it to your office and you can do it. So in this case, North Carolina Association of Pharmacists basically makes the pharmacy sort of read what it means. If you say that you administer buprenorphine, this is what it means. And I encourage you at other times to sort of scroll through, look at some of the other service sets. Pharmacists can provide contraception prescriptions through a protocol. That's an important service we heard about, yesterday as well. And NRT counseling and dispensing, that's also there. You can go to, you can look at Browse Pharmacies now, which should be right above. And if you look at the Browse Pharmacies, you can skip the filter section because there's only 6 pharmacies that do it. I think you've heard that already. But if you can actually scroll down to the actually services and check the long-acting injectable buprenorphine, then scroll down a little bit more, and you'll actually see these 6 pharmacies. I'd like to say that, well, it's true that 4 of the 6 pharmacies are in Alliance's catchment area. And I do think we're pretty awesome in this space, but I also know that it's really dependent on, these really forward-thinking pharmacies that are ready to jump in and do everything. And Gurley's Pharmacy in Durham has just been an amazing partner for 15 years and really has helped support bringing other pharmacies on board as well. But the goal is to bring this number up. So there's only 6 right now. But if you look, there's 47, or take my word for it, you don't need to search right now, but there's 47 that say they give LAIs and 40 specifically that administer LAI antipsychotics. The ones that give LAI antipsychotics should have no problem administering the Vivitrol, the long-acting naltrexone. These pharmacies also might need a little bit of education that they are able to actually administer buprenorphine because the information that was sort of thrown out in the middle of the pandemic and, in the middle of bulletin after bulletin basically said including but not limited to, and it took us a year and a half or so to get the executive director of the Board of Pharmacy to basically, of course not in writing, but to say that yes, it's okay to do buprenorphine, and then for us to get the word out, to these pharmacies. But so the first step, again, to get your local pharmacy on board is, and again, I'm trying to stress local. We heard about the little waste piece. But to try to find a local pharmacy that's already administering LAIs, and sometimes they might need education. The tailored plan pharmacy directors or tailored plan pharmacy team is really good at reaching out with these pharmacies, and they actually talk to us now because we pay them. So it works really well. And so they can sort of help talk to these folks and also actually even help you identify, there's some pharmacies, the first step is really if they're even administering long-acting injectables, not even administering, buying. If they're buying long-acting injectables, they're much more likely to be able to buy long-acting injectable buprenorphine as well. And there's actually not a lot of pharmacies in the LAI buprenorphine purchasing and even less in the Brixadi space. So we're working on that piece also because we want really the decision to be the providers, whether the patient should get Sublocade or Brixadi, not really the pharmacy based on their purchasing. And then of course, peer pressure is great. Gurley's Pharmacy has been a great pharmacy ambassador, but also for us to say, hey, we know there's 6 pharmacies that are doing this in the state, and they're like, well, gosh, if they're doing it, I better do it too. And of course, in a nice way, we do that. And then also there is some resources I listed below. A rural North Carolina researcher put on a great presentation about addressing barriers to MOUD access for rural community pharmacies. But really the LAI piece, and I don't think that was, we talked about the wholesaler issue and sort of like the nice little secret is that somehow the long-acting injectable buprenorphine does not count in their wholesaler algorithms. That's what at least they've all been telling me. And so not that we're trying to sneak around that for a bad reason, but in reality, like this can sort of help, I guess, alleviate the situation until it's hopefully fixed. And there is actually a really nice Canada published Making Pharmacies a Stigma-Free Zone toolkit. And I sort of politely have sent that to a couple of pharmacies. So feel free to reach out to the tailored plans, if you sort of have an issue, because and often it may not even be the pharmacist, it may be sort of front staff that really hasn't received the education. And so this like stigma-free toolkit really does a great job of, in very simple terms. I would be remiss to not mention other local pharmacy services. Based on time, I probably can skip that, but I think the key is that there is a lot of things pharmacies can do that to help support, the SUD population. And historically, basically we haven't, or the system hasn't paid a lot of attention to access for meds for this really complex and fragile population, at least the tailored plans work with. And we know that pharmacies can help, but the barrier is reimbursement. And so just want to tell you what we're working on, because we saw there's only 6 pharmacies doing this, and the pharmacies a lot of still don't know they're allowed to do this. Even the ones that are doing it, we have to remind them or educate them they can actually bill for this. There is, again, we mentioned the confusion about the DEA, whether the LAI BUP was included. And then we also mentioned the reimbursement issue is a problem. The injection administration is one issue. It's the 96372 that everybody gets, although that was frozen from 2021. I think the rate's different now. And while that 1736 is great for a B12 injection, it's not so great for an LAI psychotropic. That's definitely, the patient is more complex and the administration process is a lot more complex. I haven't administered risperidone Consta, but apparently you have to shake it like for, 63 times. That's a lot different than $60 they got for giving a COVID vaccine. Medicaid right now, that's the other issue, is the only payer for injection administration. So the pharmacies that are doing this service are getting no reimbursement for administration for probably half of what they're doing. So that's something that hopefully legislature can sort of mandate that everybody should pay. For pharmacies to be able to buy long-acting injectable medications, they have to have a specialized contract that some of them are not aware of. If they don't, if they just sort of open their whatever catalog, they basically will say, oh my gosh, I buy this and I get paid less than what it costs me. So basically out the door, a lot of them will say, I won't do anything. And as you probably are aware, many pharmacies are failing and closing their doors. And we cover Cumberland County. There's like 2 CVSs that are closing there. So it's not limited to just the small independent pharmacies that typically are the ones that are more likely to provide this service. But actually the chains are starting to step up too, which I think I'm excited about that. So I think Jerry alluded to the sort of pharmacy transformation initiative, sort of the work that we're doing to try to work with community pharmacies for the tailored plan population. And looking at the reimbursement barrier. And basically we had Medicaid savings from one of our years that we asked the state, and then the feds approved it, the state approved it again, how we could reinvest our Medicaid savings. And this is sort of one area that we're doing that, how to get pharmacy on board or paying pharmacy for the things that they do that really benefit our tailored plan population. We're talking about right now the long-acting injectable piece. We're also looking at tobacco cessation, med adherence, and point-of-care testing. We have a pharmacy that does ANC point-of-care testing, ClearWave, fingerstick at the pharmacy for clozapine. Like, how awesome is that? So we actually, the first study that Jerry and I did was looking at long-acting injectable medication administration in the pharmacy to try to figure out how much time does it really take to provide this service for the 1736? And sort of an incidental finding was that 31 of the 617, administrations was actually LAI SUD medication. So that was pretty exciting. We weren't looking for it. We weren't promoting it. We just noticed that. So we saw 14 Vivitrals, 13 Sublocades, and even though Brixadi had only hit the market a couple of months before this project, there were 4 Brixadis being administered too. So we were very encouraged by this. So this was happening even before we were actually out there promoting it. I think you maybe heard that Alliance, we definitely cover Medicaid. We also manage funds for the uninsured, federal, state, even some local. And part of the reinvestment funding, actually the contract was just executed yesterday, so at least for 3 counties coming up, we'll be able to actually cover LAI, BUP, and Vivitrol for uninsured folks. Yes. at least 3 counties, this is Alliance, so I'm really excited. And so just to finish up, access to actually long-acting injectable SUD medications is really critical for patients to have improved remissions, response, recoveries. We need alternative models to support telemedicine. The current model is wasteful. We're collecting data, and Medicaid is very interested in hearing about this. And basically, this collaboration model has the potential to address many of the barriers and just expand more access. And that's who we are. You know where to find us. Squeaked by. Thank you.